So over the last decade and a half, there's been a tremendous amount of information in both what we know about the epidemiology and pathogenesis of the disease, and we've been able to do a better job in characterizing patients or phenotyping them into different clinical profiles. And therapies as a result are more personalized and more specific to treat the patients that most likely would benefit from one therapy to the next. So some of the examples of that would be characterizing patients that have emphysema and specific forms of emphysema to see if they might be candidates for lung reduction if they're hyperinflated. And that lung reduction can take the forms really of, in the US, of either lung volume reduction surgery or non-US areas, if it's approved in those countries, bronchoscopic techniques. Some of those are under investigation in the US right now. A lot of studies have been done and focused on acute exacerbations of COPD because we know that that's one of the most deadly sentinel events in a patient's life who has COPD, and looking at a range of different pharmacologic, oral, and non-pharmacologic based therapies such as rehabilitation that may improve patients' outcomes. So there's been a lot of good work that's been done. There's a lot more to do, but I think that we're really on the cusp of a new era for COPD, that we can do a better job of treating patients. So the surgery itself, if you look at people, the outcomes of the National Emphysema Treatment Trial, and appropriately selected people, it shows that it can improve the trajectory of the disease. It can improve symptoms and physiology, but quality of life, but also improve survival. Not all, but some subjects. And I think what's been done really with our industry colleagues over the last decade has been developing techniques that would accomplish the same endpoint, decreasing lung volume or treating hyperinflation, and doing that in less invasive ways. Now, if we can show that those are truly in randomized controlled trials effective forms of therapy, I think that would do a lot to start turning the corner of people hyperinflated from emphysema who are maximally medically treated that may improve their outcomes and survival. Patients who predominantly have COPD are an older patient population and they've smoked. And smoking, as we know, is bad for lung and COPD, but it's also bad for development of other comorbid medical problems, from heart disease, congestive heart failure, to hypertension, to perhaps diabetes and osteoporosis. So really knowing the kind of like protean or non-pulmonary manifestations of the disease are very useful, because some of the symptoms, the cardinal symptoms, are shortness of breath or dyspnea, cough, and sputum production. Well, those 2 out of those 3 can be seen in people with heart failure or heart disease or diastolic dysfunction. So the symptoms may be confusing to the clinician and the patient, and trying to sort those out is really the work of the clinician overall, is treating the patient. To have a high index of suspicion, is it COPD or another disease that's common in that patient population that can have escalation respiratory symptoms that can present just like COPD symptoms. There's new ultra-long bronchodilators that are being developed that show high promise to improve the physiology and symptoms of patients. There was just a recent paper that was published about 2 months ago. Actually, it was presented here, the Wisdom trial, which is one of the first attempts of seeing whether we can de-escalate therapy in patients safely and without having a major impact on their outcomes. So I think more studies like that can basically right-size the therapy, not only for the patient, but right-size the therapy at the time the patient needs it, will take more traction over the next couple of years.